Mine will be a very short one. I'm Dr. Othin, anesthesia. As told on short notice, I'll try and direct my short discussion to specifically sickle cell disease. When you find these sicklers, usually the pain is... I'm Dr. Othin Moses, Department of Anesthesia and Critical Care. Specifically cardiac anesthesia, critical care. Yes, so we'll talk about pain and sickle cell disease. Usually the sicklers have, whenever they come in with, in a crisis, you have to think about two things. Acute pain, like they talked about, chronic pain, but most of the times they'll have a mixture of the two. Especially for this discussion, we are talking about patients who are opioid dependent, or those are patients who tend to be undertreated because it's already known that they are dependent, and as physicians, we tend to give much less of the drugs. But then also the fear for people getting dependent is quite huge, and so most of these patients are undertreated and they progress to chronic pain, like Dr. Peace talked about. So, but there is evidence among the sicklers specifically, those who progress to get addicted or get dependent on these drugs is quite small, about less than 3% of all patients. And so that should reduce the fear of treating these patients with some of these drugs. But then also we realize in the younger children it's more acute pain, but as you get tending towards adults, they tend to have actually more of chronic pain and less of acute pain. But most times in our management of this pain, we tend to focus on acute pain and we forget about the chronic pain. And you realize that we tend to suffer a lot with management of pain in these patients who are a little older compared to the ones who are younger. We always say that pain for us should be the fifth vital sign. So it's something that you should always make sure you look at seriously, given what Dr. Peace has talked about. If the patient progresses to get to the side of chronic pain, it's usually quite difficult to manage them and deal with them. What we tend to do, especially in the acute phase, which is basically the cornerstone of you trying to prevent them from progressing to chronic pain, is making sure you do not manage pain in a single direction. When you go down to the wards when they're managing most of these patients, pain management is driven to one side. The patient comes in, want to only give morphine. You don't think about paracetamol, you don't think about NSAIDs, you don't think about all the other things. And you find that the mechanisms of pain are multiple. Yes, the opioids could do it for you and cover much of the pathways, but that increases the risk of you getting dependent. When you use these other drugs, you find that you will need much less of the opioids, actually, and that reduces your incidence of you progressing to chronic pain, but then also them getting dependent. And so it's very important during the management of acute pain to deal with it in a multimodal approach. Dr. Peace talked about the various drugs that can be used during the management acutely. For chronic pain is a very big problem. Wherever you will go, it's something that still has to be studied. It's complex, I would say. And going forward, much of the chronic pain in the sicklers, apart from the progression because of the poorly treated acute pain, a lot of it is because of a vascular necrosis, and some of those places you will possibly never see. A vascular necrosis of the vertebrae, rare, but there are some cases that have been found, and you find the patient has almost about 5 or 6 of them necrotic, and they continue to present with pain. Specifically for this patient who comes in with this kind of pain, you realize the fixation. There is nothing else that is given to this patient apart from the morphine. They try to switch from one kind of morphine to another, and the patient is still complaining of pain. They're worried about the possibility of addiction, but they're not looking at any other modalities of treating this pain. A lot has been done, especially on the side of psychotherapy, but specifically for Sicklers, not much. Possibly if you're going to just transfer the same knowledge and bring it on the side of Sicklers. The best time to use your psychotherapy is during the phase of acute pain, so that did not progress into chronic pain. Did a study sometime here. This was specifically for postoperative pain, and we're just looking at when you counsel patients about the pain, you talk to them about it, how do they perceive it going forward? What are their pain scores going forward? And you realize that the pain scores actually not really change because of the other issues, poor pain management, they don't receive their drugs. But the fact that they were told about their pain and they understand it better, the pain seemed to be not a problem anymore. And so there is a very huge psychological component to pain, which is best dealt with not when you've gotten the problem, but in the acute phase before you go forward. There's also, especially for the chronic pain, most of the chronic pain these people get is in the long bones and things like that, and most of the times you really don't have much that you do about it. There is a lot that is done, especially with nerve blocks, and you find that they give you a single shot of a nerve block and it will take you through 3 to 4 months without any pain and stuff like that. So we need to watch out, especially amongst the older people. Very unlikely that much of their pain is going to come from acute problems, but more of chronic problems. I think sometime back still, 2017, I think they did a study here. We're looking at children between 7 to 18 years of age, Sicklers who came in crisis and painful crisis, and we used low-dose ketamine, 1 milligram per kg, infuse it over 10 minutes, and we're comparing it with morphine. And there was really no difference. You find that you got your pain relief just as well as you got the pain relief with morphine, but there were more side effects that would come with morphine that would be worried about. Respiratory depression, which we did not have any adverse effect on the side of ketamine. All we got was simple side effects. A little bit of delirium, a little bit of secretions. But after about 2-3 hours, the patient is fine, they go home. Compared to morphine, most of the morphine people, you had to be extremely careful because some ended up in the ICU, and there was always the worry of dependence. But then also, the patients who received ketamine, you realize that thereafter you needed much less of the other drugs to control their pain. It's the same for the opioids, but there were more adverse events that happened in the opioid side. And so it is one of the things that we think could possibly be used. The downside is we don't have infusion pumps because we use the pumps to give these drugs. But at the dose at which they use the ketamine, you don't expect to get any effects of respiratory depression or sedation, or if it's sedation, it will possibly be up to a RASS of possibly just 0, a very calm child. And so it's something that could possibly be used. It's something that you could possibly think about, but ultimately and most important is to make sure that you deal with pain in a multimodal approach than hinging onto one side of let's only give opioids. Thank you.